The important thing is that as long as we're all agreeing to study similar outcomes, whether you want to call it harmonizing outcomes, or I like to use just the term why push the implementation science, as long as we're looking at something, different outcomes across the multiple levels, at the patient, the provider, the system, the organization, the external level, then we can learn faster, better, more efficiently about who these models work for, in what contexts, and what kind of systems can implement what kind of models. Because, yeah, for a minute, with prostate cancer, maybe in some maybe the most optimal model that works just as well as a pretest genetic counseling model is to have the oncologist or urologist do the testing followed up by a genetic counselor. But you may not be in a system where that's even possible, so then maybe what you need to do is use a telemedicine model where now you use contracted out genetic counselors because you don't have access to genetic counselors internally. Or maybe the point of care embedded genetic counselor works best in certain healthcare systems and university models, wherever you may practice. But not every practice has those resources to be able to embed genetic counselors and genetic counseling assistants in their system. So we have to find out which ones work best and why, in what different situations and for what different populations.